The next speaker is Dr. Gary Hoffman, Professor of Medicine, Center for Vasculitis Care and Research, Lerner College of Medicine, Cleveland Clinic Foundation, Cleveland, Ohio, and he's going to talk about factors that influence organ targeting and disease patterns of systemic vasculitis.
Thank you, David. Many of the comments that I'm going to make about things that I'd like you to consider as we talk about disease patterns in vasculitis actually relate to disease patterns for any diseases, autoimmune or otherwise. But I'd like you to just think beyond just what are the characteristics that lead to diagnosis, what are the reflex things we do in regards to treatment, but think more about the why rather than the descriptive. So where are we in terms of the descriptive? It's not a great place to be, but it's functionally useful. We look at vasculitis and we talk about vessel size, and we talk about small, medium, and large vessel vasculitis. It's useful, not very insightful. We look at the histopathology, and we say whether it's granulomatous or non-granulomatous, or whether or not the lesions are associated with generous amounts of eosinophils, as in this biopsy from a patient with Churg-Strauss. We then subclassify based on organ distribution and unique features of diseases. So if we're looking at upper airway, lower airway, renal disease, other organs, we're going to call it GPA or Wegener's. If we're talking about a systemic disease with vasculitis, we're going to call it Behçet's if we're seeing mucosal, oral, and or genital ulcers. This reminds me of when we were all medical students and residents describing patterns, but not necessarily understanding what those patterns mean. It reminds me of my level of intelligence in reading EKG patterns, but not understanding electrophysiology and vectors. So what I'd like you to consider over this next 45 minutes or so are several hypotheses. These are not meant to be all inclusive, but just things that perhaps you don't consider in your everyday practice that I think if you do consider them might make solving patient problems more interesting. So I think a lot of us have been conditioned into thinking that with autoimmunity, we're almost always talking about loss of tolerance to self, to native antigen that has not been a modified antigen, and that perhaps the organ targeting that we see is because that native antigen is restricted to one organ. Or perhaps there's been loss of tolerance to circulating antigens, and then circulating immune complexes may form, and then they target certain organs but not others. But we don't usually ask ourselves why that organ and why not another. Now, there's another line of thinking that I don't think, at least I was indoctrinated into considering, and that is, could it be that the antigen that's being the driver of all of this is not native antigen, that it's modified antigen, that it's altered, and that alteration might result from many things that actually you've heard Stefan Guy talk about and Connie Wyan talk about. Could it be that we are experiencing, and we know we are, spontaneous mutations, but mutations that don't lead to cell death, that endure and provide neoantigens, new proteins? Could there be a role of infection leading to modification of self-antigen? Even if that infectious agent is cleared, could there be a lasting modification of self, perhaps by affecting the genome? Could there be modification of self because of environmental factors other than infectious agents? And then you also heard in Connie's incredibly elegant talk all about age-related degenerative changes